Hello, everybody. I'm Dr. Juan Francisco Grau. I'm a medical oncologist and doctoral researcher from Gustave Roussy Cancer Center in Villejuif, France. And I'm joined today by Alexandra Leary, who is also a medical oncologist here at Gustave Roussy Cancer Center. In this touchIN conversation activity, we'll be considering the evolving standard of care for advanced and recurrent endometrial cancer with a practice-focused discussion on the role of immunotherapy. So let's start our first section by talking about the impact approved immunotherapies are having on a standard of care for advanced or recurrent endometrial cancer. So the treatment landscape of advanced or recurrent endometrial cancer has been changing very rapidly over the last few years, and that's thanks to the introduction of immune checkpoint inhibitor, both in the post-platinum setting and in the frontline setting. So you can see that dostarlimab and pembrolizumab monotherapy were approved in the mismatch repair deficient recurrent or advanced endometrial cancer in the post-platinum setting. In addition, pembrolizumab plus lenvatinib, the combination, was also approved in pre-treated advanced or recurrent endometrial cancer patients following the results of KEYNOTE-775. And more recently, in the frontline setting, we got the approval of 3 different chemoimmunotherapy combinations based on the positive efficacy data of 3 phase randomized trials. So thanks to the RUBY trials results, dostarlimab plus carboplatin paclitaxel, followed by dostarlimab monotherapy as maintenance therapy, was approved for the mismatch repair deficient population and for the MMRP, so the mismatch repair proficient population. Pembrolizumab plus carboplatin paclitaxel, followed by pembrolizumab monotherapy as maintenance therapy, was also approved for this population regardless of mismatch repair deficient status. And finally, DUO-E led to the approval of durvalumab plus carboplatin paclitaxel, followed by durvalumab as maintenance therapy, as monotherapy in the mismatch repair deficient endometrial cancer population, and in combination with olaparib in the mismatch repair proficient endometrial cancer population. Now, Dr. Leary, let's discuss some questions submitted by our audience about the impact that approved immunotherapies are having on standard of care for advanced or recurrent endometrial cancer. So the first question is, what were the limitations of chemotherapy in the first and later lines for advanced or recurrent endometrial cancer?
Well, thank you very much, Paco. I think, indeed, things have moved so quickly over the last few years that we need to step back and remember where we were before we had immune checkpoints. And we have to remember we weren't very far ahead. We had first-line carbotaxel, and that brought a PFS of about 10 months. And once patients progressed on this first line, we really didn't have a standard of care, because standard of care is single-agent chemotherapy or hormonal therapy, which really doesn't bring much to our patients with recurrent endometrial cancer. So I think it's important to think that until 2021, we had carbotaxel, nothing else, and carbotaxel really wasn't that effective in our patients with advanced endometrial cancer.
And in the second line, I mean, the options were very limited too.
Yep.
Paclitaxel.
Yep. Single-agent chemo or hormonal therapy. And we know that single-agent chemo brings a couple of months PFS. So clearly, there was an area of unmet medical need, whether it be in the first-line setting or subsequent lines.
So our second question is, what is the role of immune checkpoint inhibitor in the later line treatment of advanced or recurrent endometrial cancer following the progression on the platinum-based chemotherapy, and how do they compare to other available options as chemotherapy or targeted therapies?
Yeah, well, not surprisingly, immune checkpoints were first tested in endometrial cancer after standard first-line treatment, okay? First thing to remember is it made sense to test immune checkpoint inhibitors in endometrial cancer because we know that 1/3 of our patients with advanced endometrial cancer are what we call dMMR or MSI. And those tumors have very high tumor mutation burdens, a lot of immune infiltrate, and it really makes sense that these patients could respond. And so as a result, there were a number of studies. Some were conducted dedicated to MSI patients. Some were conducted with 2 cohorts, MSI and MSS, in patients progressing after platinum. And what we saw was really amazing activity with a single agent immune checkpoint, whether it be pembrolizumab, whether it be dostarlimab, in patients with MSI, metastatic endometrial cancer progressing post-platinum. Here we had response rates that were the order of 50%, 50% in these patients. And when they respond for a long time. And for having treated a lot of these patients, I think there's a chance we've cured some of these patients with metastatic MSI endometrial cancer post-platinum. That concept in itself is something that we'd never even dawned on us before. So really amazing activity in this population, 30% of our patients with single agent immune checkpoint post-platinum. And the pMMR, we also tested the approach. There was some activity, but here more 10, 15% response rate. So there's something, there's a hint, but maybe that's not enough. And so as a result of a phase 2 study that had tested the combination of pembrolizumab with an anti-angiogenic, lenvatinib, which showed very encouraging phase 2 data, there was a large phase 3 study that enrolled patients with MSI or MSS, advanced endometrial cancer progressing post-platinum, and randomized them to this combination, no chemo, pembrolizumab versus standard of care post-platinum. And as we just mentioned, that standard of care single agent chemo, that doesn't work. This trial was positive, improved response rate, improved PFS, and improved OS. And this led to approvals around the world for lenva-pembro in patients in pMMR in the US, either or in Europe. Basically, this was a first really new option for our patients progressing post-platinum. Okay, so post-platinum MSI patients, you probably need an immune checkpoint alone. For your pMMRs, you're combining it with lenvatinib. And here we prolonged overall survival, which is a real, step forward.
So our third question is, how have immune checkpoint inhibitors changed the first-line treatment approach for patients with advanced or recurrent endometrial cancer, especially in the context of mismatch repair deficient or MSI high tumors?
So obviously, given the activity in the post-platinum setting, the temptation was very strong to bring immune checkpoints into earlier lines, right? We think it's probably better. The immune system is more robust in the first-line setting than post-chemo. And so a number of trials, there was actually probably a total of 5 trials around the world, evaluating the benefit of carbotaxol on its own as first-line treatment versus carbotaxol in combination with an immune checkpoint followed by the immune checkpoint as maintenance. And this led to a number of approvals, which you already mentioned, because there was a huge benefit. Now, where was the benefit? I mean, undeniable was in the dMMR or MSI high subset, where really we saw separation in the curves between carbotaxol alone versus carbotaxol plus an ICI, regardless of the ICI. That was amazing. And again, with a flattening of the curve, which really leads us to believe we may be curing some of these patients. So in the MSI tumors, I think there is no doubt you need to get an immune checkpoint in first line. Right now, the approvals are with chemotherapy. We'll probably discuss later whether we even need the chemotherapy, but really this data is unbelievable and changes the standard of care in MSI patients.
So our fourth question is, which biomarkers are the most predictive of response to immune checkpoint inhibitors in advanced or recurrent endometrial cancer, and how should they guide treatment selection?
Okay, well, I think I've just sort of partially answered that question because, as I mentioned, all of these trials that were evaluating the benefit of adding an ICI to carbotaxol in first line recruited both MSI high and MSS patients, right? And they usually analyze them according to 2 cohorts, according to stratification factor, et cetera. So clearly the benefit is much greater in MSI patients. But there is clearly a benefit also in the pMMR or MSS patient population. And again, I remind you that's roughly 2/3 of our patients. But the separation of the curves is, it's there, but it's not quite as impressive in MSI. So we're tempted to say, okay, well, how can we select among our MSS patients which ones are the most sensitive to an immune checkpoint? And here, I think we have to stay humble. I don't think we know. We have some data suggesting P53 respond better, other data saying that it doesn't make a difference. PD-L1 is not really proven to be the biomarker it is in some of the other tumors. So I would say for today, we don't know. I think we really need to work hard by doing further analyses in all these trials, keeping in mind that any of these analyses are subset analyses that are post-hoc and that are going to generate hypotheses, but won't allow us to really say how to guide treatment decisions. But I think we need a lot to learn. Probably not all of our MSS patients benefit equally from the addition of an ICI to carbotaxol, but we still have a lot of work to do on that.
So in section 2, we were talking about some of the key practical considerations for optimizing the provision of immune checkpoint inhibitor-based therapies to patients with advanced or recurrent endometrial cancer. So there are several practical considerations to be taken into account when implementing an immune checkpoint inhibitor in our daily practice. One of the most important is patient selection. We know that mismatch repair deficient patients benefit the most from immune checkpoint inhibitor therapy. However, we also know that there is a significant proportion of patients that had a primary resistance and acquired resistance to immune checkpoint inhibitor, even if they harbor a mismatch repair deficiency. And it's also important to highlight that within the heterogeneous mismatch repair proficient population, there's still a subgroup of patients that can benefit from the use of immune checkpoint inhibitor, but this subgroup of patients they're not really well defined yet. So optimizing patient selection, it's a challenge. It's a major challenge in our daily practice, and we need more reliable or predictive biomarkers of response to immunotherapy in our practice, in our daily practice. Another important consideration is immune-related adverse events that require early detection and suitable management to prevent severe toxicity. We also have to take a very careful look or careful evaluation to a special population like elderly patients or patients with comorbidities that would need individualized management. Of course, monitoring should be systematic with routine labs and symptom assessment during treatment and post-treatment. And of course, in specialized cancer centers, multidisciplinary approach is critical, and it will enhance both the safety and the efficacy of treatment. So now, Dr. Leary, let's discuss some questions submitted by our audience about the practical consideration for optimizing the provision of immune checkpoint inhibitor based therapies to patients with advanced or recurrent endometrial cancer. So our first question is how clinicians effectively manage immune-related adverse events in patients receiving immune checkpoint inhibitor therapy for advanced or recurrent endometrial cancer, while we try to ensure optimal treatment outcomes. So what is the strategy that can help balance benefit with the risks of these toxicities?
So luckily, most of us are using more and more immune checkpoint inhibitors. So we're starting to get used to these very atypical side effect profiles. It's not like chemo where you know exactly what to expect and it's cumulative. With immune checkpoints, it can affect any part of our body. So the first thing I say is the patients should be very well informed, right? And basically I tell them that anything that's new, just call us and we can evaluate whether that's something that's concerning. Because we have to remember that some immune-related toxicities, the most frequent, like a bit of thyroid inflammation or skin reaction or arthritis, those are manageable and will push through with the immune checkpoint. But some rarer side effects, such as pneumonitis, myocarditis, you can have neurological complications. These are things that you can't not take into account and manage urgently, right? And since these side effects can be so different, that's what I tell my patients. I give through a list, but I basically tell them anything new, just give us a call. Diarrhea. Diarrhea doesn't sound serious, but actually, if it's a colitis that's autoimmune, it's extremely serious. So these are all rare. There are a multitude, and they can affect almost any organ in the body. So the first thing is inform the patients, make sure they have, if you can, you even give them a card that they carry in their wallet. Give them a good information sheet with all the toxicities, okay? Second thing is the first sign of a suspected immune-related event, make a call. Call your specialist of that organ. If you're going to prescribe immune checkpoints, you need to have a network so that if you have a suspicion of pneumonitis, you call a pulmonary expert who knows how to manage immune-related pneumonitis. Same thing with colitis, with neurology, etc. Because we know that with certain immune-related toxicities, early intervention is really crucial, okay? And it's always better, in doubt, to not give the treatment until the patient's been seen by a specialist. You can skip one dose of immune checkpoint. You can make sure that you're not compromising efficacy, but you could be causing a lethal complication. So I think you inform your patient, you surround yourself with really good people, you're extremely reactive, okay? And then when we take the special instance of an immune checkpoint with lenvatinib, then here you have to be particularly cautious because some toxicities could be caused by one or the other. Colitis is probably the best example, okay? And lenvatinib can be tough going for our patients who are elderly and have a lot of comorbidities. I'd like to remind you that there was 90% grade 3/4 toxicities with lenva-pembro, and that was in patients who were eligible for a clinical trial, not your everyday routine patient with endometrial cancer. So, we'll probably discuss a little bit later the monitoring I would also recommend, but it's important to think, react quickly, don't hesitate to stop the treatment while you're working it out, and make sure your patients aren't scared to call you with anything, and I would say that's sort of a general approach.
So another question from the audience is, how should immune checkpoint inhibitor therapy be individualized for special populations, so elderly patients and those with comorbidities, while considering key biomarkers such as mismatch repair deficiency?
So that's a good question. The only thing I think it's important to state is I don't like the word individualized treatment. So ICI therapy cannot be individualized. There's only a flat dose. You can't dose reduce. You can't space them out differently. So that's important, okay? We can dose reduce chemo, we can dose reduce PARP, we can dose reduce lenvatinib, you cannot dose reduce an immune checkpoint. However, we can individualize the management of the patient, okay? And maybe that's what the audience member meant. And when we're considering elderly patients, then we know elderly patients, no matter what treatment we give them, they won't tolerate it as well. So here you enter a risk-benefit assessment, okay? And that's where biomarkers, so MSI status, can be important. If I have a 90-year-old lady who's a little bit fragile, but she's got an MSI tumor, I may push a little harder to try, at least with very close surveillance, the immune checkpoint. If I have the same 90-year-old, but she's got an MSS tumor and she's a little fragile, then that balance risk may be worth considering, and maybe it isn't worth it, okay? There's no strict rule, but I'm just saying the benefit does come into the balance when you're considering the toxicities, okay? It's important also to note in terms of comorbidities that there are some comorbidities probably that would completely contraindicate an immune checkpoint. A lot of autoimmune diseases, now I'm not talking Hashimoto's. She already has the problem with the thyroid. That doesn't contraindicate. But there are certain autoimmune diseases where really you cannot, Crohn's diseases, things like that. If in doubt, you go ask the rheumatologist, the specialist who's managing the disease. But if you have someone who has a severe autoimmune disease on an immune suppressant, you're not going to give them an immune checkpoint. So it's not an absolute rule. And again, if they're MSI, that comes into the balance. So that's, I think, something to consider. So making sure you get an input from a geriatrician if they're elderly. If they have a specific comorbidity, especially in autoimmune, make sure you get input from the specialist. And that's, again, where having a very MDT approach is really crucial for these patients. And their monitoring should probably be, let's say, more intensive than in your other patients. And here, if you are lucky enough to have nurse specialists who can follow up with your patients by phone and things like that, that's probably a good idea for these more fragile patients.
Yeah. So next question from our audience is, what are the key monitoring and assessment strategies for patients receiving immune checkpoint inhibitors in advanced or recurrent endometrial cancer beyond immune-related adverse events? So in a general...
Well, first of all, don't forget to scan them to confirm that you're actually providing a benefit with this strategy, okay? They're still receiving an expensive, potentially toxic treatment. It's important to do CT scans or whatever imaging you want regularly, okay? Because you want to make sure you're not using a potentially toxic drug in a patient who's getting no benefit. I think you have to make sure you do the correct blood tests. And that sounds simple, but actually we're so used to writing prescriptions for routine blood tests for chemo. You do those, but there's a number of other ones that you should put on there. You should make sure that you have, thyroid levels, cortisol. Probably a good idea to have baseline troponin. Yeah. There's debate on whether you should be monitoring it. I do it personally. Hepatic enzymes, of course. Keep a close eye on the imaging, because even on imaging, you can see an early toxicity. You can see sarcoidosis, which doesn't contraindicate, but it's good to know if they develop sarcoidosis. You can see autoimmune pneumonitis. So all of these things should be monitored in the blood and on imaging, where you can also see sort of an impact of this, or the side effects of your treatment. And so that's why they should have the same sort of regular follow-up as a patient who's on chemo. Now, it is true that some immune checkpoints can be given every 3 weeks or every 6 weeks, so that spaces it out, but they should still be monitored with every treatment to make sure they're not developing complications.
So our next question from our audience is, what is the role of multidisciplinary team in supporting treatment decision-making?
So again, I think we've sort of addressed this. I think it's important here. We don't need only good oncologists. You actually need other types of specialists when you're using an immune checkpoint. You need organ specialists, but that also know about immune-related toxicities, okay? You also need, most of our patients are above the age of 70. So it's good to have really good geriatric follow-up. They don't all need it. It's not just because you're 70 that you need geriatric follow-up. Sometimes you need it when you're 62, and sometimes you don't need it when you're 88. The point is, if they're fragile and elderly, they need specific input. Make sure they're not having pharmacological interactions because they're fully medicated and things like that. And so I think it's really even more important than with chemo to have a multidisciplinary team when we're talking about using immune checkpoints.
So our next question is about the limitations with current biomarkers for supporting treatment selection. It's a complicated question to
I mean, I think the one thing is there's almost no excuse for an MSI patient not to get an immune checkpoint at some point, okay? Unless there's a severe contraindications, which can happen, but it's rare. The more the question is how, can we clearly tell which MSS patients should not get an immune checkpoint? We don't know that, right? We cannot tell for sure who is not going to get a benefit. So we sort of have to probably err on the side of the best interest for the patient, and if there's not severe contraindications, giving them the benefit of the doubt with this very novel strategy. Because beyond that, I think again we need to stay modest, and we don't really know how to interpret a lot of the other biomarkers. So I would say that can't really enter into the balance today. It might change, but for today, MSI really useful. Beyond that, within the MSS, I don't think we know what to make of it.
So our next section is about how might the treatment paradigm for advanced or recurrent endometrial cancer change in the future in response to emerging data from clinical trials. So there's many challenges with current immune checkpoint inhibitor for advanced or recurrent endometrial cancer. The limited efficacy for a group of patients, acquired and primary treatment resistance to treatment toxicity that can be eventually associated with high discontinuation rates, and as we have mentioned before, the lack of reliable predictive biomarkers of response beyond mismatch repair deficiency status. There are many strategies that are being developed to address these challenges, like combining immune checkpoint inhibitor with other targeted agents, dual immune checkpoint inhibitor therapy, trying to optimize patient selection is another important approach, and trying to introduce immune checkpoint inhibitor earlier in the disease course, like in the adjuvant or neoadjuvant setting. So now, Dr. Leary, let's discuss some questions submitted by our audience about how the treatment paradigm for advanced or recurrent endometrial cancer might change the future in response to the emerging data. So our first question from our audience is, what are the most promising IC-based combination beyond chemoimmunotherapy combination that has already been approved? And what are the key challenges in implementing them in clinical practice?
So thank you. We haven't had the opportunity to mention, or it was briefly mentioned at the beginning, that there have been 2 trials that tried to evaluate the benefit of PARP inhibitors in the first-line setting in patients who had carbotaxol, and then they were randomized to carbotaxol alone or carbotaxol with the immune checkpoint as maintenance, or carbotaxol with an immune checkpoint, and then maintenance with both the immune checkpoint and PARP inhibitor. Okay? There were 2 trials. I'll limit my discussion today to one, which was DuoE, because that actually led to an approval, at least in Europe. Okay? Now, what was interesting in that study is that the stats allowed them to compare control arms, so carbotaxol alone, to carbotaxol plus the immune checkpoint, or carbotaxol plus the immune checkpoint and the PARP inhibitor. And in the MSI population, not surprisingly, the immune checkpoint did so well that adding the PARP didn't seem to do anything. But in the MSS population, there was a statistically important difference between carbotaxol alone and carbotaxol with an immune checkpoint followed by a PARP, which is interesting. And this actually led to an approval in Europe, where durvalumab, which was the immune checkpoint tested in DuoE, is approved in the MSI population, because clearly they don't seem to benefit from the PARP inhibitor. And in the MSS population, there's an approval for both Durva during the chemo and then Durva plus olaparib as maintenance. And I mean, you know, any step is a good step. But there, I'm not patient selection here. I mean, I think biologically speaking, we all believe that there's a subset of patients with endometrial cancer that probably could respond to a PARP inhibitor. But do we think it's that whole MSS population? I mean, in that population, we have ER-positive grade 1 NSMP. Do I believe a PARP inhibitor does anything in that patient population? Biologically, scientifically, I don't. So this is a case where we have an approval probably beyond our dreams, and we need to figure out who needs it and who does not need it. But I would say that PARP inhibitors clearly have a role in a subset of patients, and probably in first line after platinum. What's too bad is that this trial didn't have a fourth arm with just carbotaxol followed by the PARP inhibitor alone, and maybe some of these patients just need the PARP. So every step forward brings advances, but also more questions, and that's a perfect example here. But I would say that's the most encouraging we have so far.
Okay. And what about the chemo-free strategies, for example, in frontline setting?
So yes, absolutely. I mean, MSI endometrial cancer is so sensitive to immune checkpoints that we even have to wonder whether they need the chemo in the first line setting at all. And there are 2 trials that tested that approach. We have a trial we've led it, the Gynéco in France, but it's an international study called Dominica, where for MSI metastatic patients, chemo-naive in the metastatic setting are randomized to carbotaxol or dostarlimab. And if they have the carbotaxol arm, they can even cross over. But it'll be really interesting to see if we can actually get rid of chemotherapy altogether for MSI patients in the first-line setting, and I think that would be really, really important.
And now we are also getting more and more data of the value of the role of immune checkpoint inhibitor in the adjuvant setting. Yep. So very interesting data coming from Keynote B21 for mismatch repair deficient population. Yep. Specifically. So
yeah, I was actually disappointed because it's called a negative trial.
Yeah. When
really it is positive where it wasn't supposed to be positive. And basically this study enrolled all-comer population with high-risk endometrial cancer, but completely resected, no residual disease. And they were then randomized to standard chemoradiotherapy, carbotaxol radiotherapy at the choice of the investigator, with pembro versus placebo. And they enrolled MSI and MSS. And the trial is negative in the whole population, but when you look in the MSI population, there's really a nice separation in the curves. And if that trial had been run in the right patient population rather than in an all-comer population, it probably would have been positive. So, and that's why, today we're running a big program called Rainbow that's saying, okay, let's stop running trials in the adjuvant setting in an all-comer population. But let's run a program where we ask the scientific question and adapt the maintenance strategy to the molecular classification, right? And in that study, there's basically 4 sub-studies depending on the molecular class. The P53 mutated, we explore the advantage of a PARP inhibitor as maintenance in the adjuvant setting. The MSIs is whether immune checkpoint does better than standard chemo-RT. If they're NSMP ER positive, what's the benefit of hormonal therapy? And if they're POL-E, we try de-escalation. So I think that's where we need to be going to. Let's stop treating endometrial cancer like they're all the same. They're not. And let's try to design trials that are adapted.
So patient selection is the way to go forward. So next question from our audience is, how might emerging clinical trial data influence the future treatment paradigm for advanced or recurrent endometrial cancer, especially for those non-ICI based treatment?
So yes, there's a number of strategies that are not immune checkpoint based that are currently being explored based on our increasing understanding of the biology of endometrial cancer and of the fact, as we just mentioned, that they're not all the same and we should probably explore strategies based on the biology of the disease. I guess probably what's at the most advanced stage right now is selinexor. Just to remind you what that is, that basically inhibits the export of gene suppressors from the nucleus into the cytoplasm. And one major gene suppressor here that we want to keep in the nucleus is actually P53, right? And this is wild type P53. And so there was really nice data of a phase 3, but again, they recruited all comers, and which showed that selinexor as maintenance after carbotaxol really improved survival. But that benefit was limited to P53 wild type, which makes sense. There's no point in trying to keep mutant P53 in the nucleus, right? So I think that trial is ongoing. It's a confirmatory trial, and it's dedicated to P53 wild type first-line patients. So I think we may see, if that's positive, that could really move things. Now, we also have immune checkpoints that are standard of care in that setting, so it'll be interesting how we navigate which one we choose. Other strategies are targeting DNA repair deficiencies, right? So high-grade serous endometrial cancer looks a lot like ovarian cancer, which is why we went to explore PARP inhibitors, right? But there are also other strategies that are particularly valuable in P53 mutated tumors in general. And those are things like WEE1 inhibitors, okay? And so there's some studies going on exploring the benefit of a WEE1 inhibitor, especially in serous, likely P53 mutated endometrial cancer. And then we can't ignore the elephant in the room. Oncology is being swept by the wave of ADCs, so those are antibody drug conjugates. And I would say that endometrial cancer is probably the poster child for the best data from the Destiny pan-tumor trial, where if you selected these patients on the basis of HER2 3+ and treated them with the ADC targeting HER2, trastuzumab deruxtecan, in endometrial cancer, the response rate was 85%, which is amazing. So I think there's a lot of ADCs coming through. It's not I think, I know, and they can be targeting TROP2, they can be targeting other HER3, et cetera, HER2, and they're in clinical trials at this moment, and I think they're likely to impact the treatment landscape over the next few years.
So next question from our audience is, as new data on immune checkpoint inhibitors and their integration into treatment for advanced or recurrent endometrial cancer continues to emerge, what changes do you foresee in the overall treatment algorithm of these patients in the next 3-5 years?
Okay. Well, I think as now immune checkpoints are becoming standard of care for most of our patients in first-line setting, we're going back to where we were 5 years ago, which is what do we do after they progress on combination platinum plus an immune checkpoint inhibitor? And we're back to doxorubicin. Well, that's about as exciting as a wet sock. So really where we need to be working is what do we do in the post-platinum immune checkpoint setting? And I think some of the strategies we just mentioned, such as the WEE1 inhibitors, the ADCs, that's really where they're going. And that's probably the first place where, if the trials are positive, they'll be approved. But then you can be sure that people are going to be moving them earlier and earlier on in the first-line metastatic and then in the adjuvant setting. Because despite all these advances, and they're undeniable, we're still not curing all of our patients with metastatic cancer. So anything that works well in subsequent lines, we're very tempted to put it in the first-line setting. And I think that's probably where we're going to be going.
So thank you very much, Dr. Leary, for being here today with me and for such valuable and interesting discussion on the evolving role of immune checkpoint inhibitor in the management of advanced or recurrent endometrial cancer. And I would like to thank all of you for following this conversation, and I hope you found it enjoyable and informative. Thank you very much.
And I'd like to thank everybody, and especially Dr. Grau, for inviting me to be here. It's a pleasure to talk about advances in endometrial cancer. Nothing happened for 20 years, and in the course of 3 years, the landscape's been transformed, and that's a privilege to be here to witness that. So thank you very much.